Case of bilateral pansinusitis where the patient had severe headache. On examination on the nasal endoscopy, I could see a lot of pus in the patient's nasal cavity, and that was typical greenish yellow color pus. So I'm going to quickly run you through the basics of the CT scan of what findings I could see on the patient's CT scan basically. So this is a zero point 0.4 thickness of the CT scan, which is one of the best thickness you can ever ask for. So to begin with, you can see this is the frontal bone. Just you need to follow my cursor wherever my cursor goes away to show you the anatomy. So going behind, you can see these are the two frontal sinuses. That's the patient's nasal bone. That's the nasal septum, the cartilage part. That's the frontal forehead skin. So as we keep on going behind, you can see the opacification in both the frontal sinuses. So wherever you see black shadow, it means that it's air on CT scan and MRI as well. Wherever you see white, it's bone basically, and wherever you see gray, it's basically soft tissue. So you can see a lot of collection in the frontal sinuses on both sides, more on the right, little on the left to begin with, basically in the initial most part. And this is the interfrontal sinus septum in the center, almost in the center. You can see slightly the right side is more dominant as compared to the left one. So as we keep on going behind, now you can see the immense collection of the sinus on the right side. Now we cannot be very sure of what exactly this shadow is representing. It could be polyp, it could be just mucus secretion, or it could be mucopurulent secretion, or it could be a combination of everything above along with a lot of pus inside. Okay, so you can see more on the right side completely filling up the sinus, and you can see somewhat a two different intensities over here. You can see this is mostly grayish white, and you can see this is dark gray basically, so suggesting that this could be two different structures in consistency. Now as I keep on going behind, you can see the size of the frontal sinus is huge. So this patient has a mega frontal sinus. It's a very huge frontal sinus, and you can see almost there's a thinning of the interfrontal sinus septum on this part, because you don't much see the whitening over here. The intensity of the bone, the thickness of the bone has gone down a little bit. So you can see this is completely filling up the patient's right frontal. As I keep on going behind, you can start seeing now that the left frontal sinus is becoming more intense in collection, but the right frontal sinus has been completely the same since the very beginning. It's completely filled with the abnormal soft tissue. So you can see the huge frontal sinus. Now still the brain has not appeared on the scan so far. So as I keep on going behind, you can see now the both sides of the frontal sinus along with the interfrontal sinus septum over here, and how much of a collection you can see over here is truly a huge amount. And you can see that is the bony septations on the most superior wall. That's the roof of the sinus. Once you open the sinus intraoperatively, you will see these bony septations on the roof, indicating that this is confirmed frontal sinus of the patient. So you can see still this is the frontal sinus and not the frontal recess, because the floor of the frontal sinus is still intact, and as long as the floor of the frontal sinus is intact, it is definitely a sinus and not a recess yet. This is the frontonasal process of the maxilla, and you can start seeing now the maxillary sinus have started coming in the picture right now. So you can see this is a patient's right and this is a patient's left maxillary sinus. If I keep on going behind, you can start seeing that this is the sinus basically, and it's a common rule. You all guys have to remember that. Who's ever watching this video, resident neurosurgeon, skull-base surgeon, ENT surgeon, any expert ENT or amateur ENT beginner, always remember this one point, that whenever you see frontal sinus, you will never be able to see the maxillary sinus, or you'll be able to see the very initial part of the maxillary sinus but not the actual sinus. That's the rule, because I have seen so many scans in all these years. Never ever I found any patient to have frontal sinus proper along with the frontal sinus maxillary sinus proper in the same picture. If at all you see any structure similar to frontal sinus along with the maxillary sinus proper, that has to be a supraorbital cell or a supraorbital recess. In this patient, I'll show you that exact condition. So you can see this is the very initial part of the maxillary sinus. So now the frontal sinus should end if we go a little posterior. Okay, so you can see the floor is still intact. So there is this is still the sinus because of the patient having a huge pneumatization of the sinuses. Such patients can be an exception for that rule. So if you keep on going posterior, a little posterior towards the main maxillary sinus proper, still you would be able to see the patient's frontal sinus because of the excess pneumatization, but nothing else. Okay, so I'm going to go behind. Now what you can see is the patient's brain over here. If I keep on going behind, you can start seeing this is a patient's brain. And this is basically the patient's supraorbital cell, which exactly looks like a frontal sinus but is not a frontal sinus exactly. So I'm going to come again anteriorly. You can see over here the floor is intact. You can see over here the floor is intact. That's the nasal septum in between. Now I'm going to go behind, and now you can start seeing that the nasal floor, not the nasal floor, sorry, the sinus floor has disappeared. You can see an opening over here. That's the frontal recess basically. So this becomes the most posterior part of the frontal sinus, but somehow this is basically the initial beginning of the supraorbital recess. Now as I keep on going behind, whatever you see over here is basically a supraorbital cell along with a supraorbital recess, which I'm going to be showing you exactly in the surgery today. So I'm going to show you the surgery in detail. I'm going to be posting a link down there on this video's description panel. You can click on that link and go and watch the surgery. So you can see this is a frontal area, but this is a supraorbital recess area, and this patient has a very huge supraorbital recess and the cell. You can see I'm almost halfway to the maxillary sinus. You can see the maxillary sinus proper over here, and you can still see the patient is still having the supraorbital cell along with the supraorbital recess, and that's the brain of the patient. So I'm going to keep on going behind. You can still see the supraorbital cell over here, and you can see a huge maxillary sinus. You can see the maxillary sinus is completely full of the collection over here. So you can say on the patient's left side it is somewhat 75 to 85% involved, but on the patient's right side you can see it's almost more than 90% sinuses are involved. You can see the both ethmoids are completely involved with this the disease over here, but however the orbital contents are safe. There is no orbital involvement in this patient. There is no proptosis, no kind of any ophthalmic involvement whatsoever. You can see the lamina papyracea is also intact. The floor of the orbit is also intact on both sides. It's just the bony involvement in the sense that it has a slight expansion effect because of the immense collection within the sinuses. You can see the opening of the maxilla is also widened up on both sides. There's a huge opening on the maxillary sinus on both sides. The nasal septum, however, I cannot see any deviation whatsoever, so I shouldn't be having any problem, nor I would have to do a septoplasty on this patient. You can see somewhat there's a turbinate hypertrophy on both sides, more on the left as compared to the right. So I'll be also doing a turbinate reduction surgery on this patient with my favorite method by using a bipolar cautery, which is the best method in my practice and my experience so far. So if I keep on going behind, what I can see is that now the actual collection you can see on both sides is completely opacified. Same thing as we saw earlier. Gonna keep on going behind. Now this is a posterior skull base area, posterior ethmoidal skull base area. You can see the straight septum, but immense collection over here. So that's no involvement completely in the orbit. Now what you can see over here, the one change which you cannot see is the involvement of the sphenoid sinus. Okay, the sphenoid sinus is completely normal. However, there's a very important finding which I could see on this CT scan. As I'm going behind, You can see that's the lesser wing of the sphenoid over here, and that's the actual sphenoid sinus. So see, how do you identify that the sphenoid sinus has begun? Is that you're gonna go over here. This is the pterion. This is a pterion. This is basically the frontal bone. This is a frontal bone which posteriorly becomes the lesser wing of the sphenoid. So as I'm going on behind, you can see this bone disappears on this side, and this becomes the lesser wing of sphenoid. That's the body of sphenoid, which undergoes pneumatization and forms the sphenoid sinus. That's the intersphenoidal septa, which divides the sphenoid in the right and the left. But you can see there's a huge difference. There's a huge finding on this patient scan. You can see a huge horizontal bony septation down here, and that means this patient has a huge Onary cell on the patient's right side. You can see there are there's a presence of two horizontal, one basically an oblique crest down there, but that's basically the left sphenoid sinus. So follow my cursor where I'm going right now to show you. This is this patient's intersphenoidal septum. So this becomes the patient's right side, and this becomes the patient's left side. So do not confuse with this as a horizontal or a crest which of the Onary. It is basically the intersphenoidal septum, and this is the horizontal septation that forms the Onary cell basically. So this basically becomes the sphenoid sinus, and this becomes the patient's Onary cell on the right side. And now on the left side, you can see this is almost a horizontal to oblique bony septation over here. So this becomes the patient's Onary on the left side, and this becomes the patient's small sized sphenoid on the left side. So on the left side, which I'll be showing you on the surgery, I'll be showing you the patient's surgery. You can see the patient's sphenoid sinus over here, which is going to be a very small opening. So basically in this surgery video, I'll be showing you the patient's left side, and then later on in a separate video, I'll be showing you the patient's right side. So you can see that the sphenoid sinus is completely free of any kind of involvement. So you can see, you can be rest assured that you're not supposed to open the frontal sinus. Sorry, you're not supposed to open the sphenoid sinus as such, unless you want to see the anatomy and keep it open to prevent any future collection of pus inside. So I'll be opening up all the sinuses and be showing you the entire anatomy of this patient. So you can see once we open up the patient's Onary on the right and the left, you will be able to see this is the patient's optic nerve right here. So if we still go behind, you can see that's the patient's optic nerve. You can see a huge bulge coming from the roof, and that's the patient's optic nerve on the left. That's the patient's optic nerve on the right. So if I open up this patient's Onary cell, I'll be seeing directly head on the patient's optic nerve right in front of me. So the very important thing I have to follow in my surgery is that I have to be very careful with my instruments. Once I'm in the posterior ethmoids, I have to follow the landmarks very strictly. Otherwise, I'll be damaging this patient's optic nerve for good. And you can see this is a patient's carotid artery over here. That's the patient's internal carotid along with the cavernous sinus on the left, and this is the patient's carotid and the cavernous on the right. So if you open up the patient's right side, you'll be seeing the entire optic nerve in the Onary cell and a part of the ICA, but the remaining lower half of the ICA you will be seeing in the patient's actual sphenoid. But if you open up the patient's sphenoid and not the Onary, you will not be able to see any of the structures very carefully, because the bulge here is in the Onary and only the bony crest is in the sphenoid proper. So you won't be able to recognize the carotid unless you have opened up this particular segment of the Onary up here. Also, you can see a huge curvature of the bulge of the carotid artery over here. So once I open up the patient's left Onary cell, I'll be seeing both the optic nerve and the carotid artery along with this gap over here, the anterior clinoid process, that is the LOCR, that is the lateral optico-carotid recess over here. So this is very interesting case according to me. So I'm going to be using conventional instruments. Hardly I use debrider because I get a lot of requests from many young surgeons out there in the world out there telling me to please teach them how to use normal conventional techniques and instruments in cases, such huge cases like these. So I always prefer to use conventional instruments, and sometimes, only sometimes, a debrider for my cases like these. So going on to the very posterior aspect, you can see a huge lateral pneumatization of the sphenoid. So this is basically the lateral recess of the patient's left sphenoid, and this is the lateral recess of the patient's right sphenoid. You can see over here two holes. You can see this is the nerve, this is a nerve. So this is basically the median nerve, as I always keep on saying, viridian is median. So this is viridian nerve, and this is a V2 nerve basically. That is the foramen rotundum, basically the foramen through which the maxillary nerve exits, right? And you can see the two foramens over here. That's the viridian nerve, almost at the floor of the sphenoid sinus, and a little bit towards the medial pterygoid plate. You can see the viridian canal over here, the viridian nerve, and that's the foramen rotundum, basically for the maxillary nerve, the V nerve, the fifth nerve, second division. So as we keep on going behind, you can see the huge lateralization, or you can see the lateral sphenoid recess over here, the lateral recess on both sides. So this patient in general has a huge pneumatization in all sinuses, and that makes it very easy for us to operate on this patient, given that he also has a lot of pus collection inside. So that's all about the patient's CT scan. Nothing major beyond this. The skull base looks completely normal. The posterior part of the brain, the skull base, the brain stem looks normal. At least on the CT scan, it looks normal. So I'll be starting off with the surgical video. In the next segment, you can just click on the link down there, and you can see how the surgery is done with the most unique ways I have invented myself.